Okay, so welcome to the second series of webinars, the Imperial Global Master of Public Health. My name is Christina, and I am the Clinical Academic Lead for the Global Master in Public Health.
And I'm Catherine, and I am a Senior Teaching Fellow on the Global Master of Public Health.
Right, so the agenda for today, so I'm just going to go through some housekeeping so that you know how you can interact with us on this webinar. Then Kat's going to give us an overview of the Global Master in Public Health, including specifically or focusing on the application process and personal statement. Then we will respond to related pre-submitted questions and also do a live Q&A session with any of you that have questions for us today. Then my colleague Alex, who is also the specialisation lead for the statistical analysis with R for Public Health, now available on Coursera. He will do a subject talk, talking a little bit about his research, and then again you'll be able to interact with him through a Q&A session after his talk. And then finally, Kat and I will wrap up by answering any additional questions that have been submitted during the course of the webinar. So how can you interact with us today? Well, as you'll see at the bottom of your screen is a sort of picture and a sort of Q&A. So if you want to ask us the questions, if you click on that, and then the screen will appear, and then just type in your question, and there'll be people monitoring the Q&A and giving us those questions for us to answer. There will be specific times during the course where we will be answering those questions, so bear with us if you don't get your questions answered straight away. And finally, just to say that this webinar is specifically focused on the admission and application process, given that we have an early application deadline coming up. So any further information that we don't cover today, specifically about the course structure, the teaching and assessment methods, the entry requirements and how to apply, you can go onto YouTube on the link given, which to the webinar which we held back in February, which gives much more detail about the course structure and details about the course. Also, you can visit our webpage where all the information is available, including how to apply. And finally, we have a frequently asked questions page on the Coursera webpage for the Global Master in Public Health, which will give you additional opportunity to sort of look at some questions that you might have and get answers to those questions. So I will pass over to Kat, who will give an overview about the GMPH and also about the application process.
Thanks, Christina. It's really exciting to have everybody on the line. It seems like we've got just under 100 people. So to start off with, I'm just going to give a kind of 2-minute overview of the GMPH. So it's a 2-year part-time course, which has a strong focus in research through 4 modules, and then finishing with a dissertation where you'll write either an academic paper or a policy brief. And it has a mix of kind of theory and practice-based learning. So you get kind of a wide range of topics, whether it be from statistics all the way to health systems and foundations in public health practice type of information. There'll be a few points throughout the 2 years where you'll be able to pick electives, and those could be something from modeling of infectious diseases to something a bit more statistics heavy for advanced statistics folks, or maybe something that's more kind of practice focused as well. So kind of moving on to the application process, this is really our opportunity, or your opportunity, to learn, to tell us more about yourselves. So, this is where we sit down, we review your application in its entirety. So a CV, a personal statement, the references that you get from whomever you ask to write about you, and then we can kind of make look at sort of the whole package, what you're bringing to the table. What we're really interested in learning about you is how this will affect your career. Why Imperial? Why this program? Why public health? And that really comes into the personal statement, and I'll talk about that in a few minutes. But just kind of for starters, we review our applications on a rolling basis. So do try and get it in early, especially as we mentioned, the 30th of April is our early deadline, and our final deadline is June 30th. you can send in your application even if you don't have your English language scores in just yet, or if perhaps you're waiting for a recommendation. So do go ahead and get everything in that you can, click submit, and then we'll monitor the progress of your application and review it just as soon as everything is put in. So kind of who are we looking for? We're looking for people who have a passion for public health and who are interested in being leaders in policy, practice, research, advocacy, moving forward in kind of the scope of public health. We get a lot of questions about what kind of a background you need, and while many folks come from a medical background, that's not the only people that we get. We get people who maybe have not done any public health before but have a real interest, maybe have done some good reading or have tried to do some kind of extracurricular work around public health and are looking to kind of jump into a new career. We get people from legal, social science backgrounds, and we really welcome that. We do want to kind of let everybody know that it is a quite quantitative focused program. So you've got stats, you've got epi, and then you've got your research project, which could in fact be a qualitative project. But there is quite a lot of kind of math and science that you need to do. So we want to make sure everybody knows that in advance. It's not just because you haven't done statistics before isn't a reason not to apply, but we want to make sure everyone knows and is comfortable with the fact that is a part of our program. So what are we looking for in your application? So we want a clear account of your interest in your career goals. We want to learn more about your kind of professional background, the research you might have done in the past, related experiences that you might have had, and skills that you might have. Even if it's, you've been doing a bit of economics and you're really interested in how it ties to health, we want to hear about that. We also want you to put a bit about the research proposal that you ultimately will be writing for your dissertation. This helps us learn a little bit more about what you're interested in and gives us a good sense of sort of how you might be thinking about this very large portion of our program. And then the compelling reasons, why us, why online, and why this particular program. So we really strongly urge that you go to the website that you're shown here and look and see what our program has to offer and how you might fit in. So that's what we're really looking for. And then our personal statement. So as I mentioned, a big component of this is a big component of what we're looking for comes in your personal statement, and it's an opportunity for you to write about 1,500 words. Ideally, that's around 2 pages about yourself, and then about 150 words about that research proposal, that research project plan that you're hoping to do. So we want to know, again, more information about your drive towards a profession in public health, in your career, your interest in health and healthcare, and what you've done in the past. So we want to see that this is kind of written, it can be written like an essay, but we really want you to get into depth about who you are and what drives you. So it doesn't have to be in any one format, and we just really want you to get into who you are, because it lets us know kind of what your, why we should invite you to join our program. So that's sort of the overview of the admissions process. You'll go on to, you can get to the admissions links both from the Coursera and the Imperial websites. So we'd urge you again to put some time and effort into that personal statement. Make sure your CV's up to date so that we know what you've been doing and we can have a good sense of who you are, and apply early. And we hope to read your application soon.
Thanks, Kat. That's very useful. And just remind me, when is our early deadline again?
It's the 30th of April.
Right.
And then the final deadline is the 30th of June. And what'll happen, just also on this note, once you put in your application, it's in our system. It'll be, if you do it before that deadline, it's in our system. We'll process through everything we've got until our slots fill up. So it does take a couple of weeks for the process to kind of funnel through the central administration all the way down to our department. So don't worry if you haven't heard back in a couple of days. We are processing those as quickly as we can.
And we have the early deadline, but we are accepting, I mean, it's a soft deadline really, but and we're accepting applications sort of right up till June.
Exactly.
But once the course is full, it's full. So really it is a case of sort of, if you are interested, you are keen, getting those applications in as soon as you can.
Exactly.
Yeah, thanks, Kat. So I'm going to put up the links again. And so we're going to start our Q&A session. So first thing we do is that some of you kindly pre-submitted some questions to this webinar. And I thought we would just go through the answers to those questions first before we sort of open up to some of the questions that have been coming in as we've been live today. So I'll start off more with sort of admission process focused questions. So some of you asked whether you would need a student visa to do the online Global Master in Public Health. Well, the answer is no, you don't need to apply for a student visa. This is a fully online program, and therefore you don't need to physically attend, and therefore a student visa isn't required. Then there are a couple of questions, or actually quite a lot of questions, around funding options and scholarships. So successful applicants, you will need to check and secure funding before you start the programme. The School of Public Health this academic year is offering one scholarship for the Global Master in Public Health, and it will cover your tuition fees only. If you are keen to apply for the scholarship, it's a separate application process to the application for the programme. So I urge you again to go to our web pages to see what you need to do in addition for the application for the scholarship. Also, I would strongly encourage you to see what other scholarships you might be eligible for. A lot of countries have government funding schemes and programs for students, and also some sort of charitable organisations also provide scholarships, especially for people in sort of low middle income countries. And so that was sort of around scholarships. Then we had a whole load of other questions around sort of degree recognition and what sort of certificate you'll be issued with at the end of the programme. Well, if you successfully complete the Master's programme, you will get a Master in Public Health certificate from Imperial College London. That will be the same, equivalent to what our students currently get for the Master's programme, which is done on campus. There is no mention of the fact that it's online or distance learning on the Master's certificate, and graduates from the online programme will earn exactly the same award as our students on the on-campus, and you will receive, like I said, a Master's award from Imperial College London. In terms of whether our online programme is accredited, well, we don't have any specific accreditation from any of the professional bodies, but it is an internationally recognised degree, a degree from Imperial College. So in that respect, it will be recognised by employers across the world. So those are kind of the main areas that I've kind of covered in terms of the admissions process from the questions we had. Kat, have you got some questions?
Yeah, I do. So these questions kind of building on the questions that were asked here. So like one of the important questions that was asked was, what's the difference between an MSc and an MPH? And the long and the short answer is that one is a Master in Science and one is a Master in Public Health. Often you can see Masters in Sciences in many different areas, maybe epidemiology, but also in public health or global health. And I think, you know, basically different schools, different countries do different ways of operating. Sometimes an MPH is a bit more practice focused and more professional focused, and sometimes an MSc has a little bit more of an academic focus, but this isn't always the case. And I think both are very well recognized in academic circles as well as professional circles. So I wouldn't really worry so much about which combination of the letters. Often it's quite a similar situation. Another question we got, which is also quite important, is around the scope of the program. So Essentially, as I mentioned, it is a 2-year program. You take roughly 3 courses per term, and we're expecting that that's about 20 hours of work, academic work per week. This might be different for different people though, so you might move a little quicker, or maybe you might move a little slower. And there's a mix between theory, practice, kind of the science-based courses. This is all at your own pace. You'll get access to all of the materials right at the beginning of the term, and you'll maintain access as well during the course of your study. There'll be due dates for the assessments, and there'll be online live sessions, which will be set based on the weeks of study outlined in the course itself. But of course, you can go quicker than that, and then go back to that material when the live session is available. So that's sort of the general base of what the program looks like, what you could expect if you were to apply, get in, and enroll. And then I think the last question that I'll talk a little bit more about is, we've mentioned the research portfolio is quite a big part of this program. So explaining a little bit more about what that is. So essentially, it's a series of 4 modules or 4 specializations. The first that leads you through the entire research process, ultimately with the output, amongst other assessments, the output of your dissertation, which will either be a journal-style article or a policy brief-style paper. So in Research Methods 1, you're really focusing on the literature review, starting to define and refine your research question. In Research Methods 2, you're focusing on kind of the methods and continuing to define that question. Think about the survey you might use, or the data source that you might use. How would you look at that secondary data? What would you do to kind of process this question? The third portion is about kind of the ethics and about research applications. So thinking a little bit about how do you write a research application if you're in the real world and you want to continue on doing some more research, and getting your ethics submission prepared if you need an ethics submission. Not everyone will need one, but everyone will get the opportunity to kind of go through this process. And then the Research Methods 4 is really just you kind of writing your dissertation, working with your advisor, and getting that piece of work done. There will also be some kind of master classes, if you will, during that time period. So maybe if you're doing a systematic review, you've touched a little bit on systematic reviews in Research Methods 1, but you need a bunch more information. You need a little bit more skills, practice, someone to walk you through it a little bit further. That's when you'll get that. The overall research portfolio.
Great, thanks. So shall we see what questions are coming in? Right, so I see we have a first question from Adrienne, which was wanted really to know about sort of research and whether it was attractive, and or, what would the research portfolio look like? And I think, Kat, you explained that quite well. Yeah. I mean, essentially, we really sort of help sort of walk you through the process, and that's a really great way of doing it. So if students are struggling or feeling that they're going off track, they've got those milestones in place, perhaps, which is different to a normal on-campus degree, where at the end they have a summer project and they're left much more kind of independently to sort of steer themselves. So it's a much more guided process, I think, which is one of, I think, our unique selling points, the research portfolio. And
just to also mention, obviously it's a lot of work to do that primary data collection, and it might not be as feasible for everybody, but you can work with secondary data. You can do more of a systematic review type of a paper. So don't feel like you have to dive in and do that on the ground primary research. There's many options.
Great, and so now we've got another question from a medical doctor who's really trying to assess how feasible this is for someone who's working sort of full-time, I guess, in a fairly sort of intense profession, how they're going to fit this in with everything else they're doing. Well, I think, I'm a medical doctor myself, so I know how sort of difficult it is to sort of fit things around sort of rotas and long hours, but it really is the flexibility of the course that I think is really good. You can do it sort of anywhere from any sort of device, as long as you're online, you can follow the course, be it on a sort of commute to work, or sort of late at night, early morning, depending on if you're an early bird or a night owl. And again, you know, you really follow it at your own pace, I think. So yes, absolutely. We've designed the course with people who are working full time in mind, and you know, we are looking at sort of a sort of commitment of 20 hours a week. But I think in a sort of working week, that's possible, realistic. So we have another question from Can. I understand the program is part-time and 3 modules per semester with total 6 semesters. Can we accelerate the progress by taking more than 3 modules per semester? Yeah, no, that's a good question. The sort of the short answer is no, but you do have access to all the sort of content sort of available on the Coursera platform through the specializations that are offered as online MOOCs. However, the way that the degree will be structured with the sort of live weekly sessions and sort of online sort of chat rooms or office hours with our staff, if you really want to get the most benefit out of sort of contact with academic staff, then we would encourage that it is done at that pace where you're doing 3 modules per semester. So yeah, there is flexibility, but because of the way that the live sessions with academic staff are scheduled, it does make more sense, and you will get more out of it if you follow it in that structure. I think that's about right, Kat. Yeah, right. So hello, it's around 20 hours. So again, one from Adrienne. Hello, it's around 20 hours a week commitment. That would need a decision on workload. I think 20 hours a week is. Yeah. Oh, right, sorry, that's someone's answer. Right, let's go to, as a research scientist, do you want my academic CV or a shortened resume? Kat, from the applications you've seen, can you answer that question?
So we've seen a bit of both. I think, you know, we'd like to see things that are obviously relevant, and we'd welcome the longer CV or the shorter CV. And I think it's up to you what you'd like to present us with. In some ways, having the longer CV will show us a bit more of what you've done. But, you know, in other ways, you may feel that doesn't explain exactly what you want or show the picture that you want. Yeah. But so basically we've gotten both. There's no, you don't need to rewrite your CV entirely to make it an academic one, or shorten it if you've got an academic one, but it's sort of up to you.
Okay, and another question about sort of CV and experience from Justin. Do I need to have prior experience in medicine to apply for this course? I'm from a creative field. Sounds exciting, Justin. So Kat, I think we've been receiving applications from people from all walks of life and all disciplines.
Absolutely.
So I think, yeah, would you sort of give me a bit of experience on that?
So we definitely have received a wide variety of different applications, from theologians all the way to medical professionals. And I think public health is a wonderful field of study and field of practice because it does combine a wide range of different disciplines and a wide range of backgrounds of different folks. And so, yeah, I think if this is what you're interested in, we would be more than willing and happy and excited to have you on the program, no matter what that background looks like. I think just be sure to explain kind of how things link that you've done in the past and what your interest is.
And don't forget, public health is a really multidisciplinary field. You know, you have anthropologists, sociologists, sort of scientists, medics. We're really from sort of all walks of life. So, and that really enriches it as a specialty, that we have people from, you know, all disciplines coming together to develop creative solutions in the interests of improving population health. So really what we're really looking for, like you said, Kat, is motivation. Why are you doing it? What is the next step after the Master in Public Health? How is it going to help improve your career or change your career direction? So yeah, you know, but please, sort of, you know, we, like I said, from a creative field, yes, please apply and you know, give us your reasons, tell us why you're doing this. So another question is, I'm working and I would like to continue working while I study. Therefore, would live classes be available at a later date? Well, absolutely. The live webinar sessions that will be held weekly for the specializations will be all recorded. So there will be an opportunity to go back and look at those in your own time. I think most students will get most out of it if they can attend, because a lot of those sessions will be interactive. There'll be some group work, but don't, you know, if you can't attend, you won't miss out. You can go and watch the recorded session at a time that's convenient for you and works with your schedule. Let's have a look. Will you offer this master's program in next year's as well? Absolutely. So this is the start of something big, something long and sustainable. So yes, so this is our first year, but that we're planning on now having the course
many years to follow.
Indefinitely. Is the MPH in Health Economics offered online? So the Master in Public Health is a program. We have a Health Economics specialisation within the program, which I believe is one of the specialisations in year 2.
Yes.
So there will be some Health Economics within the Masters in Public Health, but it isn't a Master's specifically in Health Economics. So I think hopefully that answers your question.
And I think you'll get some health economics scattered throughout, you know, maybe when you're looking in the foundations of public health practice, thinking about sort of behavior change, those types of things. So,
okay, so I think we'll just have time for one more question. Kat, help me out if you can see anything quite useful. Okay, yeah, we're going to scroll right to the bottom. The last one. Hi, it was mentioned the course involves a fair bit of math, science and statistics. Are there any minimum requirements in these courses you should recommend potential students have in order to succeed in this course? Well, I think really, you know, we're for most of our courses, we're assuming sort of no prior knowledge. You know, in your application, it is useful to know what your quantitative background is. Do you have a you probably help me out with the terminology for the US, but if you have a sort of A-levels or college certificate or course in maths or science, you know, we will look at that, but not necessarily, you don't need to have a degree or a PhD in maths or statistics to do this course. We do assume no prior knowledge, and we do work you up from the ground. So yeah, but please don't feel daunted by that.
And just to add as well, the folks that work on that side of things have also provided to students on our on-campus programs, or we intend to do this as well for the online programs, some suggestions if you're feeling maybe that this might be an area that it might struggle for you, or you're a bit nervous. There's some good trainings to go to or some books to read. So, you know, you can do that over the summer before you start the course. And our professors are wonderful. So
great.
So
thanks for that. Some really interesting questions, and I hope that will have benefited the sort of wider audience, not just the people who've asked the questions. And yeah, really good questions there. Thank you. So without further ado, I am going to pass on to my colleague Alex, who's a reader of medical statistics. He's also our specialisation lead for the statistical analysis in our for public health course on Coursera, which you can go and have a look at after this webinar, and I'll let Alex talk a bit more about his research.
Excellent, thanks Christina. And just to follow on from that point, that question about how much maths or stats do you need to start, as the specialisation lead for statistics, which is in term 1 and is now free online on Coursera, I can tell you that you need none to start with, because I've designed it. I don't believe in people being able to memorize formulae and algebra and stuff. If I don't do it, I don't see why you should do it. That's what computers are for. So it will assume no knowledge and take you up to the necessary level to be a public health practitioner. You're not going to be a statistician. That's not the aim of the course. So I'm delighted to be able to talk about actually some history of the NHS, our national health system in this country, and how it's changed. hearing problem? Great. So we have an echo now.
Okay, sorry, it unmuted itself. Sorry about
Great. Okay, so technical issue fixed. Yes, I'm going to tell you about how hospitals have responded to quality of care problems in this country, in England specifically, and my role in developing a system that monitors the quality of care in hospitals and some of the scandals that have resulted and been a part of the story. And the third one, how my work has actually helped bring about a big public inquiry that uncovered some of the problems at one of our hospitals here. So what I'm going to go through in the next 20 minutes or so is talk about my unit, that's the Dr. Foster unit here at Imperial College in London, and how it is actually born out of these three big scandals that we've had in this country. I'll talk about the creation of our national hospital monitoring system using routine data. And then I'll give you a bit of information about our publicly funded mixed methods evaluation of that system, which says what happened when we found that hospitals had high mortality, how did they respond, what was the cause of the high mortality, and what happened afterwards. What did hospitals do? Did they just ignore it, or did they act on it and improve standards? It's quite an interesting story. My unit is part of Imperial College. We are funded by a research grant from a private company called Dr. Foster Intelligence, and other research grants that we win from the government. It's founded by a former GP called Sir Brian Jarman, just before he retired in 2000. And it's being led by my colleague Paul Aylin, who's one of the course co-directors since 2002. And what we do, in one sentence, is we use routine electronic data to produce and analyse measures for investigating variations in quality of care, particularly between hospitals, but also between surgeons, between doctors, and between general practices. So the first two big scandals that I want to tell you about. First one, heart operations at Bristol Hospital. So this was in the early 90s. There were a couple of surgeons operating on very small babies, and they caused a number of deaths, which I'll explain more in a minute. And people realized that actually no one was looking at quality of care very much back then, and yet we had the data to do so. The second one I'll tell you about is Howard Shipman, our legendary general practitioner, or primary care physician, who somehow or other decided to murder more than 200 of his patients. 200 patients, which is also curious because he was a very popular doctor. He had a lovely bedside manner, all his patients loved him, and yet he murdered so many of them. Really interesting and grim story. So the first one, this chap is one of the surgeons at the heart of the scandal, James Wishart, who along with his colleagues used to do these operations to fix congenital abnormalities in small children. And essentially he just wasn't very good at doing them. And here are the figures. So along the bottom, you've got age in months, and along the side, you've got the proportion of babies who died. In the kind of red and brown, that's UBHT, that's Bristol. And in the other colour, in blue, that's the rest of the country, the other specialist units doing these operations. And you can see that everywhere else, surgeons were operating on these babies in the first few months of life. That's when you should do it. That's when you get the best outcomes. But at Bristol, they did a few at that age, and they all died because they realised operating on a small heart is really tough. So let's wait till later when the heart's a bit bigger, and then we'll have a go then. and that's too late. And their mortality was much higher than the other centres. This generated a big public inquiry triggered by an anaesthetist who basically sacrificed his career to bring this to the public attention. One of the findings of the inquiry was that Bristol was awash with data. We had a lot of data about surgeon performance here, but the problem was that nobody actually was looking at mortality rates in Bristol or anywhere else. But we had the data all along. So my colleague and I did the analysis, and we showed, yeah, even with the routine administrative data, you can spot high mortalities, such as was the case at Bristol. And we did a follow-up study published in the British Medical Journal. And this showed that you can see Bristol mortality, that's in blue, and the other centres are in red. And Bristol mortality is much higher through the early 90s when the surgeons were operating. Sure enough, in 1995, when they were struck off the medical register and stopped operating, down came the mortality at Bristol to be comparable to that in the other centres. Clear case of these two surgeons not being fit to operate. Second case, Howard Shipman. So he was a GP, and he's been our most prolific serial killer. And again, he used to go around to people's homes, his patients' homes, and pay them a visit on a Sunday afternoon, murder them with a lethal injection, go back to his practice, and falsify the computer records to pretend that they looked really sick, and then that's why they died. He didn't just do this once or twice. He did this at least 200 times. But I mean, we'll never know exactly how many victims he had. So these two inquiries, as you might imagine, had quite an impact on how quality of care is monitored and investigated in this country. And here is a graph of analysis I did to see, could we have spotted Shipman's high death rate? So this is a particular kind of statistical analysis where if the red line goes above that threshold, that black line, it says, yeah, he's got a high mortality rate. And sure enough, we would have picked up Shipman earlier if we'd been monitoring the data. What also happens though is that if you do this kind of analysis, you don't just pick up Shipman, you pick up other general practices with high mortality. Now that doesn't mean that they are also serial killers, thankfully, and each of these other practices have been investigated, and they were generally practices looking after nursing homes, a very elderly, sick population. So they weren't murdering them, although other information did show that there were quality of care concerns with these other practices as well. So what did we learn from this? Well, administrative data were indeed good enough for doing this kind of monitoring, for monitoring patient outcomes. And what I learned from my time with the Shipman inquiry was this particular kind of method, statistical process control, was the best statistical method to spot such problems. And with our commercial partners, Dr. Foster, we created this national monitoring system, and which looks at mortality, readmissions, and long stays, and now also patient safety indicators. So now I want to tell you a bit about how we developed our monitoring system. So we benefit in this country from patient-level hospital data covering every admission to hospital that we have in England. And there are all sorts of cleaning routines that you need to do to get the data into the shape you need. Then you need to compare hospital outcomes, like death rates, but taking account of how the patients can differ in terms of their age, their sex, how severely ill they are, and that process is called risk adjustment. Then you need to plot the charts and see which hospitals have high mortality rates. And then, of course, you need to tell those hospitals that their mortality rates are high, suggesting that, yeah, they should look into them to see if there's a problem. Because since mid-Staffordshire, no one wants to be seen as the next hospital ripe for public inquiry. But I'm getting a little ahead of myself. We'll come on to that very soon. We adjust for all sorts of things in our data. We have information on their patient age, their sex, whether they were admitted as an elective or an emergency, their diagnosis information, the year and month, all sorts of information about them. It's quite a rich data set. And this was all published in a journal, so all my analyses and all the methodological stuff is all out there for the public to read. Those of you who like a little bit of detail will want to see exactly how we produced these charts. So we want to estimate each patient's risk of death, given their age and sex. Then you order the patients at each hospital by date of operation or date of admission. Then you want to choose your threshold on the chart. I'll show you an example chart in a minute. And there's some maths behind that, which I won't bore you with, but you can read all about in another paper. And then you want to do the actual plot itself. You want to compare the actual outcomes, so whether the patient died or whether they survived, versus their predicted risk of death, and see why and when the threshold was crossed. So here's the chart. Here is all the charts used in this monitoring system. So you've got the date of discharge, hospital discharge, along the bottom in chronological order, and you've got this statistic up the side, which is essentially a function of the difference between the observed and the predicted outcome. When the patient dies, this chart will go up. When the patient survives, this chart will go down. So the more it goes up, the more deaths that there have been compared with what was predicted. And so in this particular one, it goes up and up and up. So the risk of death, their death rate is higher than what was predicted. And over time, eventually it crosses that horizontal threshold. And at that point, we write to that hospital and tell them, you've got a potentially high mortality rate. Here are the figures, number of deaths, number of predicted deaths. For this particular set of patients, maybe patients with a heart attack or have had a certain operation. And we invite them to investigate. And when we first set up the system, we noticed that we were sending a lot of letters to the same hospital, all these potentially high death rates, which we also send to the national regulator. We sent to this hospital, and there were lots of them. In fact, there were loads. Here's one, here's another, and another, and another. In fact, there were loads, all to the same hospital, mid-Staffordshire. And combined with a big campaign by some of the relatives of the patients staying at this hospital, this led to a big public inquiry because the evidence said their mortality rate was high, which they ignored. The public, the relatives of patients who died complained about things like the nurses not having enough nurses on the wards, the nurses ignoring the patients being so thirsty they were drinking from vases, receptionists doing triage in the emergency department because of lack of staff. I mean, a horrendous catalogue of poor care, all detected from this. And there was a massive public inquiry, and it's really changed how hospitals and the NHS in general looks at potential quality of care issues. It's a shame that we had to have these 3 massive scandals to make this kind of progress, but that's how it's been. So lastly, I'll just tell you about some work that we've done in evaluating our national mortality monitoring system, because we wanted to know, has this done any good? Yes, we spotted mid-Staffordshire, where we know there were big problems, but overall, is it a good thing, or is it just a waste of time? Now, all the details are in this nationally funded report, which you can read all about if it's all freely available online. I'm just going to give you a few excerpts from it. So in brief, what we were trying to do with this evaluation is to describe the findings and the impact of the system. So we wanted to describe the mortality alert letters that we sent and the results of the investigations. So that meant, what did hospitals do? How did they react? And what did the regulator find when the regulator went in and investigated or helped the trust investigate this high mortality? We wanted to know, were they associated with subsequent changes in mortality? So after the alert letter was sent, did the mortality rate fall at those hospitals? That's what we'd like to see, of course. How did the hospitals react? And were they more likely to do other kinds of quality and safety things than other hospitals? And put it another way, what was the cause of the alert? Was it poor data quality, which is always a potential? Was it case mix, by which I mean, were the patients at these hospitals sicker than on average? Or was it due to quality of care that caused, or at least partly can cause some of these deaths? How did hospitals respond? Did they do a mid-staff? So mid-Staffordshire, unfortunately, did what this ostrich is doing in this picture. An ostrich is really good at putting their head in the ground when there's a potential problem. Now, does that do any good? No, of course it doesn't. But unfortunately, that's what a lot of hospitals did, and that was part of the problem at mid-Staffordshire. Lastly, did mortality come back down sometime after the alert? That's what we'd like to see, but did it happen? So we sent out a lot of alerts. More than 500 were sent to hospitals. The project was also looking at sepsis and acute myocardial infarction, that's heart attack. There was a particular bit of work focusing on those two in detail, which the project report goes into. We found that there's a lot of alerts and they are gradually falling year on year, which in theory is a good thing, but of course it depends on why it's falling. So what was it cause? Well, the CQC, that's the National Hospital Regulator, they investigated 3/4 of these alerts. And the big headline was that quality of care was found to be a factor in 70% of all these investigations, particularly in those with sepsis. In the other 30%, it was data issues and case mix. 70% was quality of care. So that's really quite a high proportion. And did that quality of care issues contribute to the elevated mortality? Often it did. So in 27% of those hospitals who'd had a high mortality, yeah, quality of care actually contributed to that high mortality rate in 27% of those. So again, okay, that's not everyone, there were false positives, but that's pretty high. And what did hospitals do? Well, in 77% of them, they did create a full action plan, particularly if the quality of care was identified as an issue. So that's good. So that meant if 77% were not ostrich, that only means that 23% were ostrich-like. So that's, okay, 23% too many, but that's not bad. So our conclusions, one you can't quite see, I'll read out. Our conclusions from all this is that improvements in the quality of care in the National Health Service in England has unfortunately been driven by major scandals, really those that shouldn't have happened. We've taken away the message that it's administrative data, although they are still quite noisy and messy, they are good enough to monitor patient outcomes in hospital, and they were good enough to detect Bristol. Our mortality rates often spotted quality issues. And one of my areas of research is about risk prediction. So could better risk prediction models help to reduce the false positive rate? And overall, lastly, that our system, our monitoring system, has indeed led to changes in the way that hospitals use performance information. And that is all I'd like to say. Thank you all for your attention.
Great. I think maybe we've got time for a few questions, Alex, if
Questions?
that's okay.
Yeah, I'll take any questions. So just reading down the list. Yeah, so I've had a question on how to risk adjust the outcomes. So as you'll learn about in fact, my logistic regression course online, and you'll learn in the first term of the Masters, the risk adjustment was all done using a statistical method called logistic regression. You have a binary outcome, so that's whether you died, yes or no, and then you put into that regression model patient's age, their sex, their diagnoses, all sorts of things. I had Edward asked whether this would be applicable from a veterinary perspective. You can do this kind of monitoring, performance monitoring, in any aspect of public health, I would argue, providing that you've got the data. That's what you need. In England and UK in general, we have very good data for what happens in hospitals and in primary care. Not really very much of what happens with dentists, for example, or for vets. So, but if in your country you have the information, then you can definitely do it. I think that was those. Got any more questions? Kesha, thank you very much for your comments. I'm glad that I've increased your faith in data analysis for a better future. That's why I became a statistician. I used to be a medical student once upon a time, and I moved into statistics because that was what interested me. And I can see why statistics, it's the application of statistics that excites me. It's not algebra, it's what it can do to improve public health. Chris asked about how this might spot healthcare problems in the US. Indeed, it can. You've got some great data in the US. Much of it is state-based rather than national-based, apart from your CMS for over 65s. But you can definitely do the same kind of work that I've described in your system too. Amy asked about how non-UK students would access raw medical data for research. Of course, you don't have to access UK data. So in my course, I've taken real data, but simulated from them so that that gets around any ethics issues. So that's all sorted for you for my specialization. But for your own projects, you don't have to use UK data. You can use data from wherever you're based, depending on what data you have and the access arrangements that exist in your country. I think that seems to be the lot. Well, that's great. Thanks very much for all your questions. I will pass you. Who am I passing back to? Can I pass you back to?
Well, thank you so much for that really wonderful and engaging look at sort of health systems, at some of the interesting cases from the UK and what's been done about it, and using data to have better practice, I suppose. So we really appreciate that.
No problem.
Also, thanks for everyone for being on the line today. We really enjoyed being able to answer your questions. We really hope you do put an application in. Again, just as a reminder, that early bird deadline is the 30th of April. That final deadline is the 30th of June. After this, the webinar will be posted much in the same way as it was posted before, and we want to kind of alert you to go back to those those links that we showed at the beginning of the slide deck, both to the previous webinar, which can tell you a little bit more about the program as a whole, to the Coursera platform, where you can see more about the program, and also to the Imperial web pages, which will tell you again more about the program. So thank you very much for joining us, and we hope you have a wonderful rest of your day, however long it is, depending on where in the world you're calling from. Thanks very much.